you've identified the cranial nerves in lab. All right, now what I want you to know is a little bit about their function. Okay, just like a little bit about their function for lecture, and we're good to go. So it's not just ID the nerve, but what is it? Why do we have it? Okay. All right. So we already know the mnemonic. Okay. We know most of them, 10 of the 12, attached to the brainstem. Right. We talked about that yesterday. So olfactory and optic do not. Those are in the forebrain. Okay. The vagus nerve is one that really goes all the way down into your thorax and abdomen. So the vagus nerve is quite important. We'll talk a little bit more about that in a minute. We know we have 12 of them, and we know that most of them pass through some sort of hole that we talked about in the skeletal system. Okay. These charts I'm not holding you responsible for. This is just kind of an overview of what the function of each of the cranial nerves are. So if you like a chart form, if this helps you understand the information, by all means utilize this, okay? But I'm not going to lecture off of these pictures. So this is just, again, for your reference, okay? Okay, so what should you know about nerves? That's cranial nerves 1 through 12 and spinal nerves. Spinal nerves C1 all the way down to coccygeal 1, right? So I want you to know what types of fibers there are. Are they sensory or motor? Where do they terminate? So basically, what is their effector? Like, what do they do? And then the location of cell bodies in spinal nerves. So spinal nerves, C1 all the way down to coccygeal level 1, what structures do we find cell bodies in the PNS? Where are we going to find cell bodies? In ganglia, yeah, right. Specifically the dorsal root ganglia. Okay. All right, so basically know their function, sensory or motor, or both, and know what they do. Okay, and so we have a summary here. So CN1, olfactory, okay? It's sensory only, and it's your sense of smell. Right? So here's the reason why you identified all these little holes on the cribriform plate, right? And those holes are called what? Olfactory or cribriform foramina. Yep, because those olfactory cranial nerves go through those little holes and they dangle in your nasal cavity and they pick up scent, right? They get stimulated and excited when you smell something. Okay, so what is CN2? Optic. So optic is going to be sensory only and of course involved in vision. And we'll talk more specifics about vision when we get to special senses. Okay. Oculomotor. Ocular motor in the name. Okay, so it's motor only. And it pretty much covers all of the external eye muscles that you guys were looking at yesterday, except for LR is lateral rectus and SO is superior oblique. Those two have each their own cranial nerve. Why? I don't know. You have to ask God's anatomy that one. Okay. So oculomotor handles everything else except lateral rectus and superior oblique. And it goes through the superior orbital fissure, which is an opening that we've identified. What bone is that a part of? Superior orbital fissure. Sphenoid. Good. Might as well start practicing for that final practical. Okay. All right, what's cranial nerve 4? Trochlear. Okay, so trochlear, motor only, and here's where superior oblique comes in. Okay. So how did we define left and right on the eye model? What was the trick? There's more than one, but what's the trick?
The obliques.
The obliques? What about the obliques?
They go medial.
So they originate laterally and they go medial, okay? What about the optic nerve?
It goes medially as
It goes
well.
medially, right? Towards the optic chiasm. So you can look at both of those, the obliques and the optic nerve, and figure out whether you're looking at on the left or right eye on the model. Good. Okay. All right, what's 5?
Trigeminal.
Trigeminal. Okay, trigeminal is a big one. So it's both sensory and motor. Okay. So motor, SM means somatic motor. Okay. And somatic motor neurons innervate what? What is their effector? Somatic motor.
Skeletal muscle.
Skeletal muscle, right? Okay. So muscles of mastication. So that's basically chewing. What's one of the muscles that we had to know? Masseter, right. So masseter could be one of the effectors of the trigeminal nerve. You have voluntary control over that. Tensor tympani is a muscle in your ear. We'll talk about that later. It's a protective muscle. We'll talk about it later. Talk about that now. As far as sensory goes, okay, trigeminal is the main sensory nerve of the face. A lot of people think it's facial because it says facial in the name. Trigeminal is the main sensory nerve of the face. Everything, okay? Now, there are 3 branches of trigeminal. You don't have to memorize those, okay? But it tells you kind of where that nerve traverses. So ophthalmic, it goes above your eyelids, to your upper eyelids, through the supraorbital foramen, okay? There's a maxillary branch, so it comes down, innervates the top row of your teeth, goes through the infraorbital foramen. And then there's a mandibular branch that comes down and goes all the way into the mandible and bottom row of teeth. So you get a cavity at the dentist, you have to have your wisdom teeth out, okay? That's the nerve that they're numbing. And that's why when you come out of it, everything's numb, right? You're drooling incessantly, like you can't control anything because it's like the whole side of your face is affected, right? Sensory wise. And then motor too. Okay, so trigeminal is a big one. What's 6? Abducens. Okay, so abducens is motor only. SM again, somatic motor. So here comes the lateral rectus muscle. So it has its own nerve. And that's the abducens nerve. Okay. All right, what's 7? Facial. Okay, facial's only motor. All right. And this is gonna, sorry, it's not only motor, it's mixed. It's motor of facial expression. Okay. So the sensory portion of facial nerve involves the tongue. Okay, the anterior 2/3 of the tongue. Okay. So facial is a mixed nerve, but remember, it's not the main sensory nerve of the face because its sensory responsibility is the tongue. Okay, what's 8? Vestibulocochlear, or it's also called auditory. So this is sensory only, and it's involved in hearing and equilibrium. That's why it's called vestibulocochlear. Yeah. Okay, what's 9? Glossopharyngeal. Okay, so glossopharyngeal is another mixed nerve, okay? We're just summarizing for motor. It innervates structures, just the tongue and the pharynx. So the tongue and basically the back of your throat is what glossopharyngeal does. Glosso meaning of or pertaining to the tongue. And then for sensory, it takes care of the posterior third of the tongue and those taste buds that are involved in the valate papilla. Okay, the glossopharyngeal nerve endings are on the endings of those taste buds. Okay, what's 10? 10 is vagus, not spelled like Las Vegas, right? V-A-G-U-S. So this is another big one, mixed, okay? And vagus is the only cranial nerve that goes inferior into the thorax, into the abdomen, okay? So motor-wise, we're just summarizing. It's just gonna handle muscles of the larynx and the pharynx, okay? So some of those sternohyoids, sternothyroid muscles that we identified. The vagus nerve is what takes care of that. And then sensory-wise, it goes down into your digestive canal and also your thorax. So it monitors sensation in the heart and lungs, and then also digestive organs. So vagus is kind of a big deal. If you have an injury to the vagus nerve, you're in a heap of trouble. Okay, what's 11? Accessory, spinal accessory nerve. This is motor only. Okay, this is somatic motor. 2 muscles, sternocleidomastoid and trapezius. Okay, and then 12? Hypoglossal, meaning below the tongue, which is exactly where it goes. What a big surprise, it goes through the hypoglossal canal, okay, that we already identified. So it's motor, and we're just summarizing that it innervates tongue muscles, that's it. Underneath, inferior to the tongue. Okay. Now, how are you going to remember whether a cranial nerve is sensory, motor, or both? Mixed means both, sensory and motor is the same thing. There's a mnemonic, right? So S for sensory, M for motor, B for both. Some say marry money, but my brother says big boobs matter most. I mean brains. Okay, so that's a good mnemonic for memorizing that. And then we also need to discuss the cranial nerves that have visceral motor responsibilities. Okay, so there's 4 cranial nerves that have visceral motor responsibilities. Okay, so for visceral motor, because on your handout it's going to ask you, what cranial nerves are involved? Visceral motor cranial nerves are going to be cranial nerve 3, which is what? Oculomotor, okay. 7 is what?
Facial.
Facial. 9 is? What's 9?
Glossopharyngeal.
Glossopharyngeal. And 10 is?
Vagus.
Vagus. So 3, 7, 9, and 10. Those are the cranial nerves that have visceral motor responsibilities. Okay? That's all I want you to know about visceral motor responsibilities. We're not going to go into the exact things that they're responsible for. So 3, 7, 9, and 10. This is super early. I should just keep on going. You guys just want me to keep on going? I might as well just keep on going because there's just a lot of time left. Okay. All right. And the sooner I finish it, the more time we have to review and such. Okay. So, any questions about any questions about cranial nerves? Functions, sensory motor, both, okay. All right. Okay, again, a lot of this you've done in lab already, so it's nice. Spinal nerves, okay, 31 pairs. C1 all the way down to cossogeal 1, right? So we have 8 cervical, how many thoracic? 12, how many lumbar? 5, how many sacral? 5, okay? All have mixed function, sensory and motor. So every single spinal nerve carries sensory and motor information, right? And spinal nerves connect to the spinal cord via what structures? Dorsal and ventral what? Roots. Because a nerve doesn't just boop attach to the spinal cord, it splits because sensory enters one way and motor exits another, right? Okay, so nothing new here. It's just, again, gives a visual. Okay. Repetition is key. Connects to the spinal cord by the dorsal root and the ventral root. Dorsal root carries sensory only. Ventral root carries motor only. Cell bodies are located in the dorsal root ganglion. Do we have a ganglion in the ventral root?
No.
No. Why? Because it's motor. Why? Why is there no ganglion? Because anatomically motor neurons are what? What structure are they? Are they unipolar, bipolar, multipolar? Multipolar, right? So their cell bodies are found where?
Gray matter.
In gray matter. So you will not have a ganglion for motor neurons, right? You will have a ganglion for sensory neurons because structurally they are unipolar, right? And so that lends their cell bodies to be outside of the CNS in a ganglion. Okay. Awesome. Okay, so here's just an example. Again, similar to what we've seen before. So here's our spinal nerve carrying two kinds of information, both sensory and motor. Sensory is blue, motor is red, okay? I talked to you briefly about a ramus. Ramus is the first branching off of a spinal nerve, okay? So the first branch off of a spinal nerve is called the ventral or dorsal ramus. Rami is plural, okay? Okay. So depending on where these nerves are going in the body, okay, they're ultimately coming from a ramus. They're either coming from a dorsal ramus or a ventral ramus of that particular spinal nerve. Okay, so we'll get more into that later when we talk autonomic. All right, so sensory information comes in through nerves, okay, depending on where in the body it's coming in from. So this looks like it's giving you sensory information in the skin, okay, of the forearm. So that information goes in, enters the dorsal root, cell body is found in the dorsal root ganglion, and then it synapses where?
The gray matter.
Gray matter specifically where?
Posterior.
In the posterior or dorsal horn, right? And it's going to synapse with interneurons, which are gray here, and that's where processing and analysis occurs. Okay, interneurons are myelinated or unmyelinated? Unmyelinated if they're found in the gray matter. Again, if we're talking about tracts that exit and go up to higher processing centers, then some of those interneurons are myelinated. Okay, it just depends. Okay, so those interneurons then are going to synapse with motor neurons where? Anterior horn, or what other option do we have? Lateral horn, right? Because what kind of motor neuron cell bodies do we find in the anterior horn? Somatic motor neurons. In the lateral horn we find visceral motor cell bodies, right? So this is just showing you somatic motor, exiting out the anterior root, going down a spinal nerve and terminating, it looks to me like on the biceps. Okay, so again, just a nice nerve pathway. So, the dorsal and ventral ramus, okay, both contain sensory and motor fibers. Let me back up so you can just see that. So each ramus is going to have both, okay, sensory and motor, just like a spinal nerve, okay. And these rami will go down and they'll branch into your peripheral nerves, okay. So your brachial nerve, your femoral nerve, you know. If we're at the level of C5 to T1, yeah, you're going to get your musculocutaneous, your radial, your ulnar, your median, okay? If we're down at the level of L1 to L5 in the lumbar plexus, you're going to have your femoral nerve, okay? And then the sacral plexus, you'll have your sciatic nerve, your tibial nerve, your common peroneal nerve, okay? Okay. The rami communicantes, okay? This is a structure, you don't have to know this right now. We're going to talk about this in the next unit of study. But that basically allows the rami to communicate with a structure that we identified in lab, the sympathetic trunk ganglion. And the sympathetic chain or trunk ganglion, okay, ganglia, collections of cell bodies, okay, but it runs all along the lateral aspect of the spinal cord on both sides, and it allows for communication between the levels, okay? So that's the level of detail. This is basically just showing you that same model that we have in lab, where you've got the ganglion on both sides. You've got enlargements where the cell bodies are gonna house. You have a spinal nerve here that's exiting. You've got the posterior root, you've got the anterior root that allows the spinal nerve to connect to the spinal cord. You've got your dorsal root ganglion, and then once that spinal nerve exists, boom, it's gonna branch into a dorsal ramus and a ventral ramus. And then coming off of the ventral ramus, we've got this special structure that we'll talk about later called the rami communicantes that then immediately, boom, hits the sympathetic trunk ganglion and allows for communication between the different levels. We'll talk more about pathways in the next unit of study, okay? Okay. So this is just a summary slide, okay? We've gone over this already. Okay, so afferent we know is leading towards the CNS. Efferent is going away. If we're talking about somatic motor, we know it's the anterior gray horn where you find those cell bodies. Okay, if it's visceral motor, we know it's lateral horn already. Okay. So where are cell bodies of interneurons found in the spinal cord? We already said that's the dorsal or posterior gray horn because that's where they're synapsing with those sensory neurons, taking in information and analyzing, right? The dorsal or posterior gray horn is where you're gonna find cell bodies of either somatic or visceral sensory neurons, right? Nothing new, and just repetition. And we know that spinal nerves carry both sensory and motor information. So if we're talking about spinal nerves, okay? Spinal nerves means like C1, C2, 3, 4, 5, 6, 7, 8, T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Once you get further out into the periphery, then you start forming brachial, femoral, radial, ulnar, okay? That's further down. But they all originate from spinal levels, and those spinal levels have spinal nerves, okay? Okay. All right. Okay, so when we're talking about rami, let me go back here real quick. Okay, so we've got the first branches of a spinal nerve, dorsal and ventral rami, okay? When we're talking about rami, so when we're talking about further down the chain, femoral, all those peripheral nerves you guys just identified in lab, okay? All of those nerves come from a ventral ramus. So a majority of the nerves in your body are coming from a ventral ramus of spinal nerves, okay? Dorsal ramus goes dorsally, and how do we define dorsal? It's on the back side, right? So it's gonna go to your back, all right? So, because it's called the dorsal ramus, dorsal rami are gonna innervate your back muscles, your erector spinae, okay? So this transverse slice, right here, sternum, so we're anterior, vertebra posterior, okay? You've got a spinal nerve coming out. Here's a ventral ramus. That's eventually gonna come anterior and become whatever peripheral nerves are at that level. Posteriorly, okay, it's going into spinalis. What's the next muscle?
Longissimus.
Longissimus, and then iliocostalis. So there you go. Dorsal rami are innervating back muscles. Okay. Okay. Now, ventral rami, okay, include intercostal nerves. So let me just back up for a moment here. So when we're in the thorax, so when we're where the ribs are, okay, all the innervation in the thorax is housed by intercostal nerves that interlace in between our ribs. And those intercostal nerves are coming from a ventral ramus between T1 to T12, because that's where our ribs are. and that's a ventral rami. So ventral ramus includes not only peripheral nerves, arms and legs, but also intercostal nerves in the trunk. Okay? That's all I really need you to know from that slide. Just intercostal nerves, that's it, coming off of ventral rami. Okay, don't worry about lateral and anterior cutaneous nerves. Too much detail. Okay, so we looked at this in lab, we looked at a plexus. We know a plexus is a group of nerves. We have 4 main plexuses in the body. A plexus is a collection of ventral rami, okay? Except for in the thorax, because in the thorax, we just have intercostal nerves, okay? So ventral rami, aside from intercostal nerves, are mainly going to serve your arms and your legs. Dorsal rami are going to serve your back. Okay. Don't worry about fibers crisscrossing. Okay. Okay. So plexuses are collections of ventral rami. The cervical plexus, we said, is C1 to C4. Brachial, C5 to T1. Lumbar, L1 to L4. Sacral, L4 to S4. Okay, so those are the ventral rami from those spinal nerves that makes up a plexus. Okay, so now I want you to remember certain nerves that are associated with each of these 4 plexuses. And a majority of this you've already looked at in lab, the way it's listed on your lab handout, which is nice. Okay, so cervical plexus we know is in the neck. One nerve I really want you to know that's super important in the cervical plexus is the phrenic nerve. And the phrenic nerve is spinal level C3, 4, and 5, and the way we remember that in PT school is C3, 4, and 5 keeps you alive. Does anyone have an idea of what muscle the phrenic nerve innervates? The diaphragm, right? Without the phrenic nerve, you wouldn't be able to breathe on your own. Okay? So if somebody has a cervical spinal injury at C3, 4, or 5, and it compromises their phrenic nerve, they will be on a breathing apparatus. Okay? If you cannot contract your diaphragm, you cannot breathe on your own. Okay, so that's cervical. Brachial are the nerves that we're identifying in lab. Axillary, radial, musculocutaneous, ulnar, and median. So just those 5 are associated with the brachial plexus, which we said is C5 to T1. Okay. So in the brachial plexus, this is a really nice picture of the brachial plexus. I can tell you in PT school, I had to draw this and memorize it. All of it. All the nerves, all the levels, everything. We had to draw it and memorize it. So we had to know roots, we had to know trunks, we had to know the divisions, and we had to know the chords. And so I always remember really tired, drink, coffee. That was my mnemonic. So you'll get there. But for now, we just know that there are 5 nerves associated with the brachial plexus. Okay? Okay. Musculocutaneous innervates biceps brachii and brachialis. That's where the nerve goes. You can identify that on the arm model in lab. The big arm shows you musculocutaneous diving right into the biceps. Median nerve is anterior forearm, so palm side. Okay. Ulnar nerve is more like medial hand. It's more like pinky and ring finger kind of a thing, inside of the forearm. Don't worry about the chords. Radial is all along the back, right? So radial nerve innervates what on the back of the arm?
Triceps brachii.
Triceps brachii. And then what about in the forearm in general?
Extensors.
Your extensors. Right? Median is more your flexors. Okay. Axillary wraps around the head of the humerus, goes into your armpit, innervates deltoid, which is right there, and teres minor, which is right below in the back. Okay, so that's axillary. I had a patient once come in with axillary nerve palsy, really odd, I have no idea where it came from, but him trying to elevate his arm I mean, it was the weirdest pattern because he was trying to do it just using his supraspinatus because his deltoid just completely shut off. So it was a very interesting movement pattern that he presented with. And he tried his best, but it was like, whew, you don't have that deltoid. It really does allow you to elevate your shoulder. So we worked a lot on strengthening and getting him back to normal function. Okay, so what happens when things go wrong? Okay, there's a couple things. So if there's damage to your brachial plexus going out into the arm, you can present with a couple different things, okay? First one, wrist drop, okay? So that's very end picture, wrist drop. That's a radial nerve injury. And that's a radial nerve injury because why is your wrist dropping? What muscles aren't working?
Extensors.
Your extensors aren't working, so you flop into flexion, right? You can't extend. So they call that wrist drop, okay? Claw hand, yeah, don't worry about that one. Median nerve injury, I like hand of benediction better, so just don't worry about ape hand. Look at hand of benediction. So for median nerve, okay, because it's flexor side, goes into the fingers, okay, if you can't flex, your fingers stay extended. And so that's why they call it the hand of benediction. This is kind of like the Pope blessing the people. Okay, so that's why they call it the hand of benediction for somebody that has a median nerve injury. And then the last one that I've seen before is crutch paralysis. So that's where somebody gets crutches at the hospital. Here, go home, use these. They don't get told how to use them. They're not fitted for their height. So what do people love to do on crutches? Lean on them, right? Just get in the armpit and just lean on them. And that just pisses off your axillary nerve, and they start complaining of numbness and everything. And so by the time I see them, it's like, oh, good God, let me guess. No one told you how to use crutches properly. And you're 5'10", but they're fitted for a 5'2" person. So no wonder you're so hunched over. So it happens pretty frequently, crutch paralysis. So fortunately, you can catch it early enough to where it's not a real issue. But patients will start complaining of pain, soreness, rubbing, irritation, tingling, things like that. Okay, so that's that. That's probably the most common conditions that you're going to see with a brachial plexus injury. Okay, as far as lower extremity for lumbar plexus, again, we know L1 to L4 already. Okay, we know femoral nerve and obturator nerve come from it. Femoral nerve is going to innervate what muscles? If it's anterior thigh muscles, what muscles live there?
Quadriceps.
Quadriceps, right? Obturator nerve innervates adductor muscles. So what adductors do we have to know? Adductor longus, adductor magnus. What's another thin one that goes all the way down the medial aspect of the thigh? Starts with a G. Gracilis. Yeah, gracilis. So those are all obturator nerve muscles. Okay, and then finally we have sacral plexus. You hear lumbosacral plexus, but that's just if they combine the two plexuses together, depending on what kind of an injury somebody has. So for us, sacral plexus is going to be more posterior, okay? We have identified in lab already tibial nerve and common fibular. So if tibial nerve is innervating most of the posterior lower limb, what muscles are those? Gastrocsoleus, yeah. Yeah, common fibular or peroneal nerve. What kind of muscle do you think that would innervate? That you already identified. Fibularis or peroneus longus. Yep. Goes to that. Okay. So again, all of these peripheral nerves are coming from ventral rami of spinal nerves. And since we're talking about sacral plexus here, it's going to be somewhere from L4 to S4. We're just not memorizing that level of detail. Okay, so the very last concept then are dermatomes. And dermatomes are basically a sensory map of the body. So it's an area of skin that's innervated by a single spinal nerve. What does C1 provide you in terms of sensation? What does T5 provide you in terms of sensation? Regardless of the peripheral nerves that are involved in it, what kind of sensation do you get from each spinal nerve, okay? Okay, so here's an example of a dermatomal map. So you can see that C1 to C4, pretty much cervical plexus takes care of sensory to the neck, okay? C5 to T1, that's brachial plexus, right? So that takes care of pretty much, T1 comes all the way around the medial aspect here, takes care of arms, okay? The thorax, okay, has its own intercostal nerves that are going to give each level its own sensation. And then lumbar plexus, L1 to L4, is going to give you the sensation across mainly the anterior aspect of your upper thighs and a little bit of your lower legs. And then posteriorly, for sacral plexus, it's going to give you sensation of your glutes and then hamstrings and calf region, so posterior lower extremity for the most part. So if somebody comes in, say with like radicular pain going down the arm, oh my God, I have like a herniated disc in my neck and it's radiating down and it's just killing me. It kills my thumb and my first finger or whatnot. I may have them, close their eyes and I may check some of these areas for sensation. And I'll just use like a pen tip or something and have them close their eyes and just say, okay, tell me if you feel it, yes or no. And I'll just do my little test and they'll say yes or no. And then I always compare the opposite side so that you know what their normal is. Maybe they're not as sensitive on both sides. That certainly can happen. Same thing if I'm checking a reflex. I always do reflexes on both sides because you don't know. Someone might be naturally hyper-reflexive or hypo-reflexive. You don't know what everybody's normal is. So you always check the other side. And then that can give me more information as to like, okay, well maybe C5, C6 is involved. As a PT, I know, okay, well C5 involves biceps, brachialis, a little bit of the upper brachial arm, so maybe I will do some strength testing of those specific muscles to see if there's any weakness. And I'll do strength testing of both sides. So it kind of gives me a better idea functionally of where the patient is showing weakness and how that's contributing to, I can't put I can't do a button-down shirt anymore because I can't feel the buttons, or I can't wash my hair because just putting my hands over my head for more than 30 seconds, it just kills that arm. I just can't do it. So there's all different kinds of presentations that patients give you that you just have to kind of take each bit and fit it into a puzzle piece and develop your plan of care. Okay, I think we finished. Oh no, just some disorders. Okay, so I'm only gonna go, I'm only gonna cover the ones that you're really gonna. Shingles, very painful. If you know of, grandmother, grandfather, aunt, uncle, mom, dad that has had shingles, it's basically chicken pox coming back to bite you again. So all of us that have had chicken pox, we are rife for having shingles as we get older, which is why there's a shingles vaccine. So shingles is it's a viral infection, but usually it's stress induced, and it's very painful. So it starts off typically in the trunk as a splotchy something, and then it spreads, and the pain is neurological. It usually follows intercostal nerves. It's extraordinarily painful. People that have shingles don't wish it on anybody. I haven't got the shot because I heard it's one hell of a needle, and I'm just really? I don't know if I want to do that right now. But, so anyways, shingles is just a viral infection, and if you stress out too much and you get it, it's your PNS on overdrive. Okay. Anyone that's had migraine headaches know how horrible they are. So again, migraine headaches just have to do with the dilation and constriction of your arteries in your cerebral hemispheres. So people that have migraines tend to like to drink caffeinated beverages to dilate the arteries and release the pressure type things. But some people get Botox injections in their neck to help relax the musculature because you get so tense that then the tension drives another migraine, and a lot of these people are like sensitive to light. You can't function if you truly have a migraine. It's not a fun experience. And then myasthenia gravis, for any of you that have heard about it, it's yet another disorder where your body starts to attack itself, and it's autoimmune, which means your antibodies start destroying your acetylcholine receptors, and we know how important acetylcholine receptors are for muscle contraction. So if the receptors get destroyed, then muscle contraction gets affected, and it's a progressive weakening, similar to multiple sclerosis. Okay, so that's pretty much it, just those three. Again, migraines are just not, whew, you are out of commission if you have a migraine. Myasthenia gravis takes a long time to manifest itself and then to progress. It's not something that's overnight. Okay, questions? Perfect.